Good morning, everyone. We apologize for the delayed start. We are going to go ahead and officially open the pop-up emergency February 28th and March 1st ACIP meeting.
She's on.
Next slide. The slides presented at today's meeting are available on the ACIP website. The live webcast videos will be posted on the ACIP website after the meeting, and meeting minutes are posted on the ACIP website generally within 90 to 120 days of the meeting. We are posting short meeting summaries, executive summaries of the meetings, about within the week after ACIP meetings, of the emergency ACIP meetings. Next slide. We are actually going to pause on this slide for a minute. We are very fortunate to be able to welcome our CDC Director, Dr. Rochelle Walensky, to join our call and open up the meeting for us. So we are shifting it over to see her on video, and welcome Dr. Walensky. Give us 1 minute.
She's supposed to turn the video.
Can you all see me?
We can see you.
Oh, great. I just wanted to be here to thank you. I know that the work that you all do is extraordinary. I know that the timing is not always ideal and not always in the daytime or working week hours. And I know that you have had numerous Sunday meetings in the context of this pandemic. So I just want to say that I know the work has been hard, it's been voluminous, it's been heavy, and you're making critical decisions. And so I just wanted to be here as you embark on this day with some really important decisions for our nation ahead, to say thank you for the work that you're doing, thank you for the hard decisions you're making, and for the contribution. People are listening, people are engaged, people really want to know what this important advisory committee has to say. So I just wanted to, from the bottom of my heart, thank you for your efforts here. This will not be the last, which I suppose is good news for our country. So I know your dedication is truly longitudinal and has been throughout this pandemic. So just wanted to say thank you. Thank you, Dr. Cohen.
Thank you, Dr. Walensky. We appreciate your joining us during this opening, and your words are much appreciated, I know, by all of the members who have been truly extraordinary over the last year. Going back to our meeting logistics, we ask that everyone who is on the Zoom call please mute their lines. When Dr. Romero opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Romero will first take questions from voting ACIP members and then from ex officio members and liaison representatives. We will try to stay on schedule. We do have a public comment session today that is scheduled, and we will keep that as much as we can on the scheduled time. Please disable your video except for during the vote. Next slide. I just wanted to let everybody know about our next regularly scheduled ACIP meetings, June 23rd and June 24th, and October 20th and October 21st. As we are all aware, there are likely to be, hopefully not too many, additionally scheduled meetings to evaluate and respond to COVID vaccine issues between these times. Next slide. We do have an oral and written public comment open for this meeting. We have an oral public comment session before the vote at today's meeting. Individuals registered to make public comment, and more individuals registered than we had slots available, so we did a randomized lottery to select the individuals that were asked that were given the opportunity to speak at today's call. Additionally, anyone can submit any public comment at regulations.gov, and you can see the docket ID at the bottom of the slide, CDC -2021-0021. And all of the ACIP voting members, as well as all of the public, have access to this docket and can review all of those comments. And we really appreciate them and encourage you to do that. Next slide. Members of the ACIP have forego participation in certain activities related to vaccines during their tenure. There are limited conflict of interest waivers for individuals who serve on vaccine clinical trials or DSMB boards specifically. Those individuals will be asked to recuse themselves from votes related to the products of that company or that vaccine in which they are participating in the clinical trial. For all COVID vaccine votes, we do have a member or two who may be funded by the National Institutes of Health to work on COVID vaccine clinical trials. But because they are working on authorized products or products under investigation, we're still asking that they recuse from votes. At the beginning of each meeting, ACIP members will state any conflicts of interest. Next slide. And just want to remind everybody that ACIP membership nominations are open. We welcome any and all applications for membership. They're due no later than July 21st for the 4-year term period beginning July 2022. And we will be sending out emails through our listservs to solicit nominations. Next slide. So in closing, I do just want to give a brief overview of today and tomorrow's session to prepare everyone. The agenda today, and Dr. Beth Bell will go into this more fully, is focused on the decision and anticipated vote to recommend the Janssen product, which received its EUA authorization from FDA last night. Tomorrow, there will be continued discussions about clinical considerations, implementation considerations for use of this vaccine and the other 2 authorized vaccines. So today's session is really focused on the Janssen vaccine, and more general issues will be discussed tomorrow. We'll also have a safety presentation in tomorrow's session. I'm going to hand it over to Dr. Romero, who will begin our roll call.
Thank you very much, Dr. Cohn. Thank you all for being here. So I will now call the roll. We'll start with the voting members. When I call your name, please state your affiliation and whether you have any conflicts. So begin. Ms. Bata?
Good morning, Lynn Bata, Immunization Clinical Coordinator at the Minnesota Department of Health. No conflict.
Thank you. Dr. Bell?
Beth Bell, Clinical Professor, University of Washington, Department of Global Health. No conflicts.
Thank you. Welcome. Dr. Bernstein?
Good morning. Hank Bernstein, Professor of Pediatrics, Zucker School of Medicine, and Hofstra Northwell. No conflicts.
Good morning. Welcome. Dr. Chen?
Wilbur Chen, Professor of Medicine at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I was involved in clinical studies of COVID vaccines until October 2020.
Thank you. Welcome. Dr. Daly?
Matt Daly. I'm a senior investigator at Kaiser Permanente, Colorado, and I also have an affiliation with the University of Colorado School of Medicine. No conflicts of interest.
Thank you. Welcome. Dr. Cotton?
Emil Cotton, Clinical Director of Transplant and Immunocompromised Host Infectious Disease at Massachusetts General Hospital and Harvard Medical School. No conflicts.
Welcome. Thank you. Dr. Lee?
Grace Lee, Professor of Pediatrics at Stanford, Associate CMO at Stanford Children's Health. No conflicts.
Good morning. Welcome. Dr. Long?
Sarah Long, Professor of Pediatrics at Drexel University College of Medicine in Philadelphia. I have no conflict.
Dr. McNally?
Good morning. This is Veronica McNally, president of the Franny Strong Foundation, and I have no conflict. Thank you.
Dr. Paling.
Good morning. This is Kathy Paling, professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine. I have no conflicts.
Dr. Sanchez.
Good morning. This is Pablo Sanchez. I'm a professor of pediatrics at Nationwide Children's Hospital and The Ohio State University. I'm a neonatologist and pediatric infectious disease specialist, and I have no conflict.
Thank you. Welcome. Dr. Talbot.
Good morning. I'm Dr. Talbot. I'm an associate professor at Vanderbilt University Medical Center, and I have no conflict.
Thank you. I'm Jose Romero. I'm the chair. I am the Secretary of Health for the state of Arkansas and a professor of pediatrics, pediatric infectious diseases at the University of Arkansas for Medical Sciences. So next I'll turn to our ex officio representatives, and I will call their institution and ask them to indicate whether they're present or not. Starting with Centers for Disease Control.
Nancy Messonnier. Good morning, everybody.
Good morning. Centers for Medicare, Medicaid Services.
Good morning. This is Mary Beth Hans representing CMS.
Good morning. Food and Drug Administration.
Good morning. Doran Fink here for the U.S. Food and Drug Administration Office of Vaccines.
Welcome. Good morning. Health Resources and Services Administration.
Good morning. This is Mary Rubin from Division of Injury Compensation Program.
Welcome. Good morning. Indian Health Service.
Good morning. This is Tom Weiser from the Indian Health Service.
Good morning. Welcome. National Institutes of Health.
Good morning. This is John Bagel, National Institute of Allergy Infectious Disease, NIH.
Good morning. Office of Infectious Diseases, HIV/AIDS Policy.
Good morning. David Kim, OIDP.
Good morning. Now we'll turn out to our liaison representatives, starting with American Academy of Family Physicians.
Good morning. Pamela Rockwell, Associate Professor, University of Michigan. Present.
Good morning.
No conflict.
Good morning. American Academy of Pediatrics.
Yes, good morning. Bonnie Maldonado, Professor of Global Health and Infectious Diseases, Chair, Committee on Infectious Diseases, American Academy of Pediatrics.
Welcome. Dr. Kimberlin, American Academy of Pediatrics Red Book.
David Kimberlin, editor of the AAP Red Book.
Welcome. American Academy of Physician Assistants.
Good morning. Marie-Michelle Léger, Director of Clinical Education at AAPA, American Academy of PAs.
Welcome. American College of Health Association.
Good morning, Sharon McMullen, Cornell University, and also responding for my co-liaison, Dr. Tavi Chai of University of North Carolina, Chapel Hill.
Good morning. American College of Nurse Midwives.
Carol Hayes, present.
Welcome. American College of Obstetricians and Gynecologists.
This is Dr. Linda Eckert, professor at the University of Washington in Seattle of Obstetrics and Gynecology and Global Health. Good morning.
Good morning. American College of Physicians.
Good morning, Dr. Jason Goldman, affiliate professor at Florida Atlantic University, community private practice, representing the American College of Physicians. Pleasure to be here. Thank you.
Good morning. American Geriatric Society.
Ken Schmader for AGS.
Welcome. Good morning. America's Health Insurance Plans.
Yeah, Bob Gluckman, Chief Medical Officer, Providence Health Plans, Portland, Oregon.
Good morning. American Immunization Registry Association.
Good morning. Rebecca Coyle, representing the American Immunization Registry Association.
Welcome. American Medical Association.
Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory. I'm the liaison for the American Medical Association.
Good morning. American Nurses Association.
Good morning. Chad Ruddle, representing the ANA.
Good morning. American Osteopathic Association.
Dan Grog, representing the American Osteopathic Association. Good morning.
Welcome. Good morning. American Pharmacists Association.
Morning again. This is Steve Foster.
Welcome. Association of Immunization Managers.
Good morning. This is Molly Howell representing the Association of Immunization Managers.
Welcome. Association for Prevention, Teaching, and Research.
This is Paul McKinney, Professor, School of Public Health and Information Sciences, University of Louisville.
Good morning. Association of State and Territorial Health Officials.
Good morning. This is Nirav Shah, the Director of the State of Maine Center for Disease Control on behalf of ASTO.
Welcome. Good morning. Biotechnology Innovation Organization.
Good morning. Phyllis Arthur for Bio.
Welcome. Council of State and Territorial Epidemiologists.
Good morning. Dr. Christine Hahn, Idaho State Epidemiologist representing CSTE.
Welcome. Canadian National Association, sorry, let me try it all over again. Canadian National Advisory Committee on Immunization. Canadian National Advisory Committee on Immunization. All right, I will come back to that. Infectious Diseases Society of America.
Good morning. This is Jeff Duchin, Health Officer for Public Health, Seattle and King County, and Professor in Medicine at the University of Washington, representing the Infectious Diseases Society.
Welcome. International Society for Travel Medicine.
Elizabeth Barnett for the ISDM. Good morning.
Welcome. Good morning. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACO, present.
Welcome. Good morning. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield representing NAPNAP.
Welcome. National Foundation for Infectious Diseases.
Good morning. This is Dr. Bill Schaffner. I'm a professor of preventive medicine and infectious diseases at Vanderbilt and medical director of the NFID.
Welcome. National Medical Association.
Good morning. Dr. Pat Whitley Williams, professor of pediatrics, Rutgers Robert Wood Johnson Medical School, representing the National Medical Association. Thank you.
Thank you. Pediatric Infectious Diseases Society.
Good morning. Sean O'Leary, present.
Welcome. Good morning. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Welcome. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman representing SAM.
Thank you. Society for Health Care Epidemiology of America.
Good morning, Marcy Dries, hospital epidemiologist at Christiana Care and associate professor of medicine at Thomas Jefferson University, representing SHAE.
Thank you very much. I'll call, let me see if Canadian National Advisory Committee on Immunization is present. I see not. Okay, that ends our roll call. So thank you very much for all coming today's emergency meeting, February 28th, 2021. I'll gavel it into session and we'll begin, I guess, with our first presentations. I will ask Dr. Beth Bell to please give an introduction on coronavirus disease 2019 vaccines. Dr. Bell, will you please?
Thank you very much, Dr. Romero, and good morning to everyone. I wanted to reflect on the fact that this meeting marks almost exactly 1 year from the first COVID-19 associated death in the United States. And over the course of the past year, more than 500,000 people in this country have lost their lives to this virus. This is the 11th emergency meeting of the ACIP on COVID-19. And during this time, we've made recommendations for 2 vaccines that received emergency use authorization from FDA. As you'll see today, COVID cases and deaths are decreasing, but the pandemic is very far from over and many challenges are before us. The need for more safe and effective vaccines remains urgent and vital to ending the pandemic. And today we need to consider a third vaccine that was authorized for emergency use yesterday by the Food and Drug Administration. Could I have the next slide, please? During February of, I guess that's still this month, the COVID-19 vaccine work group continued to meet weekly. During this month, the topics we covered included an overview of adenovirus vector vaccines, the clinical development program for Ad26-CoV-2, the Janssen COVID-19 vaccine, the grade and evidence to recommendations framework for Janssen COVID-19 vaccine, considerations for the use of COVID-19 vaccines, and safety updates. Next. As I just mentioned, on February 27th, 2021, the Food and Drug Administration issued an emergency use authorization for the use of the Janssen COVID-19 vaccine for the prevention of coronavirus disease 2019, COVID-19, for individuals 18 years of age and older. Next. As Dr. Cohen mentioned, today's agenda will focus on the Janssen vaccine, we'll begin with an overview of Janssen's single-dose COVID-19 vaccine Ad26-CoV-2.S from Janssen Pharmaceuticals, companies of Johnson & Johnson. We will hear the grade analysis of the Janssen vaccine by Dr. Julia Gargano of CDC. The evidence to recommendation framework for the Janssen vaccine by Dr. Sarah Oliver. Then, as Dr. Cohen mentioned, there will be a period of public comment, followed by a period discussion period and an ACIP vote on the Janssen COVID-19 vaccine. Next, please. Tomorrow's agenda will focus on a number of accompanying issues related to both the Janssen vaccine and COVID-19 vaccines in general, beginning with a presentation by Dr. Kathleen Dooling of CDC about implementation considerations for COVID-19 vaccines, then clinical considerations for the use of COVID-19 vaccines by Ms. Jessica McNeil, also of CDC. We will have a session on vaccine safety tomorrow, beginning with an introduction by Dr. Grace Lee, who is the chair of the Vaccine Safety Technical Subgroup, otherwise known as VAST, co-chair. A COVID-19 vaccine safety update by Dr. Tom Shirandakuro of CDC, and closing the safety session with the assessment of VAST of the safety data to date by Dr. Grace Lee. Finally, tomorrow we will have a presentation about emerging SARS-CoV-2 variants from Dr. Heather Scobie of CDC. Next, please. Again, I'm actually happy and proud to show this list of the work group members and thank them for their continued participation, wisdom, contributions, and willingness to continue to address these important issues. And next, please. Here is a list of the CDC participants. Again, contributions. We really could not do our work the way we have been doing it without their extensive contributions. Next, please. I think that's it for me.
Thank you very much, Dr. Bell. So before we ask Dr. Tawoji to give her presentation, I'm going to ask Dr. Fink from the FDA to please make some comments. Dr. Fink, please.
Thanks, Dr. Romero. So I've been asked to provide an update and a summary on the Vaccines and Related Biological Products Advisory Committee meeting that FDA convened this past Friday, February 26th, to discuss Janssen's request for emergency use authorization of their COVID-19 vaccine The meeting agenda opened with a presentation by FDA to refresh the advisory committee on emergency use authorization and consideration specific to COVID-19 vaccines. We then heard presentations from the CDC on epidemiology of COVID-19 strain variants and post-marketing surveillance data from currently authorized COVID-19 vaccines, as well as a presentation from FDA on plans for additional post-marketing surveillance. Following a public comment period, we heard presentations of data from studies of the Janssen COVID-19 vaccine that were made first by representatives of Janssen, and then the FDA's presentation with our comprehensive and independent review of the data submitted by Janssen in their EUA request. The meeting concluded with a discussion by the advisory committee and a vote. And to cut to the chase, after the usual in-depth discussion and questions from the committee that really left no stone unturned, the committee voted unanimously in favor of a determination that the known and potential benefits of the Janssen COVID-19 vaccine outweigh the known and potential risks in support of issuing an emergency use authorization for the vaccine. Important questions and points that were raised by more than one committee member included that the case definition for moderate to severe COVID-19 used by Janssen in their clinical trial really was all-encompassing of symptomatic disease, as there were very few symptomatic cases in the trial that fell outside of that case definition. However, FDA raised the point that the authorized indication for the COVID-19 vaccine for Janssen, which would be the same as for those previously authorized for Pfizer and Moderna, would be prevention of COVID-19 due to SARS coronavirus 2 without any specification of severity of disease. The committee also inquired about currently ongoing study being conducted by Janssen evaluating a two-dose regimen of their COVID-19 vaccine, and asked what would happen if data from that study indicated that a two-dose regimen was potentially more effective or offered greater benefit than the single-dose regimen for which emergency use authorization was requested. FDA advised the committee that if new data were to come to light supporting a two-dose regimen, that there were regulatory options either under revision of the emergency use authorization or under a biologics licensure application to support use of a two-dose regimen of the vaccine. The committee also inquired about ongoing studies to evaluate effectiveness of the vaccine against asymptomatic infection as well as transmission. And these studies are ongoing, not just for Janssen, but for the other authorized coronavirus vaccines as well. And data should be available at the time that biologics licensure applications are submitted, if not before. The committee was very interested in further development of not just this vaccine, but other COVID-19 vaccines for use in pediatric populations. And those studies are either ongoing or about to begin imminently. Finally, the FDA asked the committee to opine on efficacy in subgroups in the clinical trial, specifically in adults 60 years of age and older with comorbidities. The committee members did not express serious concerns about vaccine efficacy in that population specifically, and generally were in agreement with the conclusions of both Janssen and the FDA that the vaccine was highly effective against COVID-19 associated hospitalization and death, and that apparent differences in vaccine efficacy estimates between certain subgroups were likely a result of smaller numbers of cases in those subgroups, leading to imprecision in the estimates. The committee member, in their unanimous recommendation in favor of emergency use authorization, felt it was important to make sure that the public understood that this vaccine appears to be highly effective for all populations for prevention of COVID-19 related hospitalizations and deaths, and that it is also important not to compare this vaccine with other authorized vaccines because they have not been compared head to head and were evaluated at different times and under different conditions. Thank you very much, and I'll return the mic back to Dr. Romero.
Thank you very much, Dr. Finger. So let's go forward then. We'll have a presentation by Dr. Duoji on the title overview of Janssen's single-dose COVID-19 vaccine, AD26 COVID2.S. Dr. Duoji, please go forward.
Good morning, and thank you. My name is Makaya Duogi. I head clinical development and medical affairs for vaccines at Janssen. I want to thank the committee for the opportunity to present data from our development program as we seek your recommendation for how our COVID-19 vaccine will be used in communities across the country. As we all know, while 2 FDA-authorized COVID-19 vaccines are already being distributed, there remains an urgent need for effective and safe vaccines in order to vaccinate a majority of the U.S. population, ensure protection against severe disease, and subsequently reduce the burden on the healthcare system. And now that the FDA has authorized our vaccine candidate for emergency use with an indication to prevent COVID-19 caused by SARS-CoV-2 in individuals 18 years and above, the vaccine will be able to play a critical role in the global fight for COVID-19. AD26 CoV2S was studied in a large phase 3 study. We enrolled more than 44,000 participants and conducted the study in multiple countries during the height of the pandemic. It offers substantial protection, especially against severe COVID-19, including hospitalization and death, irrespective of variants. It is well tolerated and safe, and it is a single-dose regimen with storage and transportation conditions that are compatible within existing distribution channels. Specifically, Janssen's single-dose vaccine has demonstrated early onset of protection against symptomatic COVID-19. Particularly important in the context of a pandemic, we've observed 85% vaccine efficacy against severe COVID-19, both globally and including the United States, at least 28 days after vaccination. For this key secondary endpoint, the effect was consistent across geographic regions, including in South Africa, where we saw 95% of the strains were the emerging variant of the B.1.351 lineage. Importantly, for the primary analysis, there were no COVID-19 related hospitalizations in the vaccine group versus 16 in the placebo group. And there were no COVID-19 related deaths in the vaccine group compared to 5 in the placebo group. In the United States, we showed 72% vaccine efficacy at least 28 days after vaccination. We enrolled more than 19,000 participants in the U.S. and paid particular attention to ensuring a diverse population was recruited. Our primary endpoint was achieved with 66% vaccine efficacy for moderate to severe critical COVID-19 for the overall study population after day 28, and protection was observed as early as 2 weeks after vaccination. We saw consistent efficacy across age, comorbidities, race, and ethnic subgroups. These results are particularly important when one considers where and when we studied our vaccine. Our study sites were located in areas where COVID-19 incidence was highest and where variants were emerging, including in South Africa, Brazil, and the US. And still, the vaccine efficacy against severe critical COVID-19 was high. Based on sequencing of approximately 72% of COVID-19 cases in our study, it's evident that the prevalence of new variants was close to 70% in Brazil and greater than 90% in South Africa. Of note, we did not observe the P1 strain in our Brazil sites. These efficacy rates are based on the total data set, including non-centrally PCR-confirmed cases. During the last 2 months, we've seen that it's critically important to manufacture and distribute vaccines quickly and efficiently. And Janssen's vaccine offers logistical and practical advantages to help simplify distribution and expand vaccine access. Each person receives a single injection of 0.5 ml. The application of a single-dose regimen offers the ability to vaccinate the population faster. Each vial contains 5 doses, and no dilution is required. The vaccine can be stored for 3 months at normal refrigeration temperatures and has a 2-year shelf life when kept frozen. We've continuously improved our manufacturing and formulation processes, and today, now that we've received EUA from FDA, we are poised to begin shipping and delivering enough single doses to vaccinate 20 million Americans by the end of March. This is part of our overall commitment to supply 100 million doses to the U.S. government in the first half of this year. And it can be easily shipped using existing supply chain infrastructure. In addition to these key features, Janssen has substantial clinical experience with more than 193,000 people vaccinated with our Ad26-based vaccines. These studies were conducted across continents, including participants of various ages, races, and ethnicities, and also included vaccination of pregnant and breastfeeding women in our Ebola program. Our Ebola vaccine was licensed in Europe in July of 2020 and is currently part of a mass vaccination program in Rwanda. Regular reviews of the safety database have shown overall good tolerability and safety. Local and systemic reactogenicity are in line with what we've seen with licensed vaccines. And databases that searches focused on adverse events of special interest have not received and have not revealed any safety signals to date. So let's look at an overview of our key studies in the comprehensive development program. We've performed numerous animal studies, including those in non-human primates, to study vaccine immunogenicity and efficacy. Our phase 1/2A study led to the dose selection for our phase 3 studies. Study 2001 is a phase 2 trial investigating a range of dosing regimens. Our ongoing pivotal phase 3, COVE 3001, is examining the efficacy, safety, and immunogenicity of a single-dose regimen, as you've heard. Data from this study were submitted to the FDA in support of our application for emergency use. So today's presentation will provide the readout of this ongoing study. Since our initial analyses, some additional information on cases observed have become available, which will help to address some of the questions those results could have triggered. And we'll also share this with you today. We also have a series of planned studies. We're evaluating the efficacy of a 2-dose regimen, as you heard, in study 3009, and we estimate that we'll have results available later this year. We will conduct several immunogenicity and safety studies in children from 17 years of age down to neonates. The study in adolescents will open, we hope, next week. We are also anticipating starting a study in pregnant women in the 2nd and 3rd trimesters towards the end of March, early April. We also plan to begin studies in immunocompromised individuals in the 3rd quarter of this year. In addition, Janssen plans several post-authorization observational studies to assess vaccine safety and effectiveness in the real world, and this will include the development of a pregnancy exposure registry. So now I'll describe our established AdVac technology platform that is the core of the Janssen COVID-19 vaccine, and also provide an overview of how we designed the vaccine and evaluated its immunogenicity. Moving to the next slide. By design, the Ad26 vector is replication incompetent. The E1 regions shown in blue and the E3 regions shown in yellow are important in the development of our vector vaccine. By deleting E1 from the adenovirus DNA genome, the virus irreversibly loses its ability to replicate in human cells. And we've also deleted most of the E3 gene. What this does is essentially create more room for the genome for a transgene, shown in purple here, that codes for the protein that triggers the desired immune response. For the production of replication-incompetent viral vectors, we use the well-characterized Percy6 cell line that complements for the missing E1 gene. The vector can only replicate in an E1 complementing cell line, and again, cannot replicate in the human body. Of note, the Percy6 cell line grows in a medium that's free of animal components. And a vial of our Ad26-based vaccine contains a buffer with commonly used ingredients in vaccines. There are no adjuvants, antibiotics, or preservatives in our vaccine. First, a single dose is injected into the muscle in order to deliver the transgene to a diversity of cells. The transgene encoded spike protein is then expressed on the surface of these cells. Innate immune responses triggered by the Ad26 vector provide the optimal microenvironment for the immune response against the spike protein. Attracted antigen-presenting cells then pick up the spike protein and migrate to the lymph node, eliciting both humoral and cellular immune responses. The CD4 T helper cell responses are predominantly of a Th1 phenotype and stimulate B cells. Spike-specific antibodies are then produced by plasma cells. These antibodies have SARS-CoV-2 neutralizing antibodies and also Fc-mediated antiviral effector functions that may play a key role in vaccine-elicited protective immunity, including protection against the new SARS-CoV-2 variants of concern. Spike-specific CD8 T cell responses are also triggered. CD8 T cell responses mature into cytotoxic effector cells with the ability to kill virus-infected cells. This is an important effector mechanism of vaccine-elicited antiviral immunity. Finally, FDA guidelines classify adenoviral vectors as non-integrating, meaning they do not have the propensity to modify the host genome. So now I'll show some preclinical data. A single dose of Ad26 CoV-2S gave full protection against SARS-CoV-2 challenge in non-human primates. We observed near complete protection against viral replication in the nose and full protection in the lung. This protective efficacy was durable for at least 6 months, and high-level protection against lung viremia was seen even after vaccination with a full 4-fold lower dose in the face of lower antibody titers. In addition, a single dose also gave near complete protection against viral replication in the lungs of aged non-human primates. To complement our NHP studies, we tested our vaccine in Syrian golden hamsters, where it also demonstrated protective efficacy. And histopathology in animals with low-level breakthrough infections demonstrated no evidence of vaccine-associated enhanced disease. You can find more information on this in your briefing materials. Overall, these results satisfied the FDA guidance criteria to allow for progression into human clinical trials. And since we've had an opportunity to review with this committee the previous design and results of our phase 1/2 trials, I'll just provide a high-level summary here. Following a single dose of Ad26 CoV-2S, neutralizing antibody titers were elicited in the vast majority of adults, independent of age. Titers were detected as early as 14 days post-vaccination, which increased in the following weeks and was maintained thereafter. And this was irrespective of the vaccine dose used. Both CD8 and CD4 T cell responses were observed. The Th1 dominance of the CD4 T cells, in combination with the neutralizing antibody response, minimizes the risk for vaccine-associated enhanced disease. In addition, we tested 2 doses, and while both had a favorable, and 2 dose levels, I should say, so 5 times 10 to the 10th and 1 times 10 to the 11th, and while both had a favorable safety profile, the lower dose had a more favorable reactogenicity profile. And so we selected the lower vaccine dose of 5 times 10 to the 10th viral particles of Ad26 CoV-2S for the phase 3 study CoV-3001. Now let's go to the results from our phase 3 study, known as Ensembl. Our primary analysis shows that the study met its primary endpoints, demonstrating the ability of a single dose of Ad26 CoV-2S to protect against moderate and severe critical COVID-19 in adults, and that it has an acceptable safety and reactogenicity profile. So I'll just refer to our vaccine going forward as Ad26 for brevity. 3001 is a randomized, double-blind, placebo-controlled phase 3 trial that's evaluating the efficacy, safety, and immunogenicity of a single dose of Ad26. We randomized participants 1-to-1 to receive an injection of either vaccine or saline placebo. Randomization was stratified by site, age, and the absence or presence of comorbidities. And the first part of our study consisted of a safety run-in phase. Stage 1A enrolled 2,000 adults up to the age of 59 without comorbidities. Following a planned safety review, then enrollment was able to progress to Stage 1B to include participants up to 59 years with and without comorbidities. We did the same in stage 2A, which began in parallel to stage 1A and enrolled 2,000 participants 60 years and above without comorbidities. This cohort did take a little bit longer to recruit. After a planned safety review where the DSMB identified no safety concerns, we progressed to stage 2B to include those 60 years and above, both with and without comorbidities. And since those over the age of 60 are at higher risk for severe COVID-19, we targeted at least 30% of the total population to be in this age range. So onto the co-primary endpoints, which were vaccine efficacy to prevent moderate and to severe critical COVID-19 with onset at least 14 days post-vaccination, and also with the onset at least 28 days after vaccination. The primary hypothesis is that the lower limit of the 95% confidence interval of the point estimate is above 30%. This had to be met for both primary endpoints in order to declare success. The case definition for moderate COVID-19 was a positive PCR or molecular confirmation of SARS-CoV-2 infection, plus at any time during the observation period at least one new or worsening sign or symptom as listed in the panel on the left, or you could have at least two new or worsening signs or symptoms suggestive of COVID-19 on the right. So for example, if a participant had a sore throat and a headache, this was sufficient to be considered moderate. Now here's the case definition for severe critical COVID-19. For this, participants had to have a positive PCR or molecular test confirmation of SARS-CoV-2 infection, and then any one of the listed signs at any time during the observation period that you can see on the slide. We have a blinded clinical severity adjudication committee to evaluate all severe cases as well as moderate cases that had at least 3 signs or symptoms. Classification of a case as severe critical by the adjudication committee was considered definitive. So next we can move to disposition and efficacy results. So on the next slide, you can see that we randomized a total of 44,325 participants, of which 43,783 received an injection of either Ad26 or placebo, making up the full analysis set. And this is the safety population. The per protocol population is the primary efficacy population and includes all participants who were seronegative at the time of injection and had no other major protocol deviations judged to possibly affect the vaccine efficacy. Participants were also excluded when they had a positive PCR test result at the day of injection. The per protocol at-risk set includes all participants in the per protocol population, but excludes those with a positive PCR test between injection through day 14 or day 28. So the next slide shows the overall demographics of the global study population at baseline. So looking between the two groups, we see no relevant differences. Efforts were in place to reach predefined targets for subgroups to ensure good representation in terms of age, race, ethnicity, and sex. I'll highlight here the number of participants who are 60 years or older across both groups. Enrolling significant numbers of participants in this age range was important for evaluating vaccine efficacy, and I had mentioned previously we had a target of 30% for the whole population. Also to note, nearly 20% of the full analysis set were frontline or essential workers or healthcare professionals. And then here's the same table, but just looking at the baseline demographics for participants from the US. And here we see no relevant differences between groups. We see a similar proportion of participants 60 years and older in the US, as was shown globally. And more importantly, participants are representative of the US population in terms of race and ethnicity and reflective of the diversity of the population. Next slide. Given that people with pre-existing comorbidities are at higher risk for developing severe COVID-19, it was important to enroll participants with key risk factors. Approximately 41% of those enrolled had at least one comorbidity. And the table also shows the most common comorbidities across the global population, meaning with at least 2% in either group. And as you can see, participants who are the most vulnerable for developing COVID-19 related symptoms were well represented in the study overall. Now, if we look at the US subgroup specifically, the percentages are similar to the overall trial population and are distributed between the vaccine and placebo groups. The full table is presented in the briefing document. Now let's review the co-primary endpoint results. Study 3001 met both of its co-primary endpoints, accruing 464 primary endpoint cases between September and January. The co-primary endpoint analysis includes all PCR-positive cases that were confirmed at a central laboratory. The vaccine efficacy against moderate and severe critical COVID-19 is approximately 67% after day 14 and 66% after day 28. You can see that the lower limit of the 95% confidence interval was well above the FDA requirement of 30%. Over 99% of accrued cases met the moderate to severe COVID-19 case definition. Therefore, the primary endpoint is representative of nearly all symptomatic COVID-19 cases. Looking at the co-primary endpoint in the U.S., we see that the vaccine efficacy against moderate to severe COVID-19 is 74% after day 14 and 72% after day 28. On the next slide, we see the cumulative incidence curves for moderate to severe COVID-19, and they begin to separate between the Ad26 and placebo groups around 14 days after vaccination. And this is suggestive of the timing of onset of protection. The circles represent the severe cases for each group. Because of the rapid accumulation of cases due to high COVID-19 incidence during the conduct of the study and the time it took for central lab confirmation of local PCR tests, not all cases could be confirmed by the central lab at the time of the primary analysis. So there are two data sets. And the first one consists of PCR positive COVID-19 cases confirmed at a central laboratory and is used in the co-primary and secondary efficacy analyses. However, we anticipated that subgroup analyses would require a larger data set to draw conclusions, and we wanted to look at all confirmed COVID-19 cases that required hospitalizations or led to death. So we pre-specified that a second data set could be used, which included all COVID-19 cases with a positive PCR and any FDA-approved test, regardless of central confirmation. To justify the use of this second data set, we looked at agreement of the positive PCR results from the central lab versus all other sources, and we found that these data sets have high concordance. We also wanted to test for consistency between these data sets with regards to vaccine efficacy and found that there was less than a 1% difference between them for the co-primary endpoint criteria. And this is true for both time points and therefore justified the use of the larger data set. We had several secondary endpoints in the study. In the interest of time, I'll just focus on the key ones. So overall, vaccine efficacy confirmed severe COVID-19 occurring after day 14 was high, at least at approximately 77%, and increased to about 85% after day 28. There were 14 versus 60 cases of severe COVID-19 occurring after day 14 in the Ad26 group versus placebo, respectively, and 5 versus 34 cases occurring after day 28 in the Ad26 group versus placebo. When we look at the Kaplan-Meier curves for moderately confirmed severe COVID-19 cases, you can see that vaccine efficacy starts at day 7 or earlier, indicating early onset of protection. Protection continues to increase over time, and this points to the potential for longevity. And notice that after day 48, there were no more cases in the vaccine group versus 13 in the placebo group. And so this is a depiction of the vaccine efficacy against severe COVID-19, and it's showing that it increases over time, as denoted here by the black line. Looking through day 56, we see an estimated increase in vaccine efficacy to approximately 92%, with no indication of waning thereafter. And the gray area is the point-wise confidence interval, which reflects the uncertainty around this estimate, which increases, of course, beyond the median follow-up of 58 days due to the small number of participants at those time points. Data also demonstrate a substantial effect of the prevention of COVID-19-related hospitalizations, with 93% vaccine efficacy for all PCR-positive cases from any source after day 14 post-vaccination. And the protective effect is even more pronounced after day 28 with 100% vaccine efficacy. There were 19 deaths in the study overall, 3 in the Ad26 group and 16 in the placebo group. 5 of the deaths in the placebo group were confirmed to be COVID-19 associated and were reported prior to the January 22nd cutoff. None of the deaths in the vaccine group were COVID-19 related. A 6th COVID-19 related death occurred in a participant in the placebo group who had a positive SARS-CoV-2 PCR test at baseline. And so based on our protocol, this participant was not included in the COVID-19 related death count or efficacy analyses. We did look at the deaths after the primary analysis and identified 6 more between the initial cutoff date and February 5th, 2 in the vaccine group and 4 in the placebo. One of the deaths in the placebo group was confirmed to be COVID-19 associated as compared to none in the vaccine group. All COVID-19 associated deaths occurred in South Africa. We also evaluated the effect of AD26 against asymptomatic, undetected SARS-CoV-2 infection to gain insight into the potential benefits of vaccination on transmission. Based on SARS-CoV-2 and IgG testing alone, 18 participants seroconverted in the AD26 group compared to 50 in the placebo group, resulting in vaccine efficacy of 66%. A sensitivity analysis was done to remove all participants with a positive serology result at day 71 who had symptoms between day 29 and day 71. 10 seroconversions occurred in the AD26 group and 37 in the placebo group. These findings are preliminary, and while the formal analysis will occur once all participants reach 6 months post-vaccination, these data do suggest a protective effect of the vaccine on asymptomatic SARS-CoV-2 infection. So now I'll show vaccine efficacy by key demographics and by country. And here we see vaccine efficacy against moderate to severe critical COVID-19 is consistently observed across all pre-specified subgroups by age, so 18 to 59 and 60 and older, by comorbidities, by sex, and by the largest racial and ethnic groups. We do note a lower vaccine efficacy point estimate with wide confidence intervals was observed for the subgroup of participants 60 years and older with comorbidities compared with the overall population. However, our assessment, as you heard earlier, is aligned with that of the FDA, but there is an observed trend of increasing efficacy with narrower confidence intervals as numbers of cases in the analysis increased. And therefore, we are also aligned with the FDA that those 60 years and older with comorbidities are similar to any other subgroup and would benefit from vaccination with AD26. Across the 3 key countries, vaccine efficacy against moderate and severe COVID-19 was consistently high. The majority of participants were enrolled in the US, Brazil, and South Africa, and these were also the countries that contributed the most to most COVID-19 cases in our study. The forest plot illustrates that AD26 consistently protected against moderate to severe COVID-19, and vaccine efficacy after day 28 ranged from 64% to 72% across the 3 countries. The VE against severe COVID-19 was consistently high across these countries as well. South Africa, for example, had 82% protection after day 28. And what's important to know is that 95% of the sequence samples in South Africa were associated with the new highly transmissible variant from the B1351 lineage. So we investigated cases in South Africa further and found that there were no hospitalizations in the AD26 group and 6 in the placebo group. Also, there were no deaths in the AD26 group and 5 in the placebo group. These findings strongly suggest that AD26 is efficacious against this newly emerging and rapidly spreading strain. So to summarize efficacy, a single dose of AD26 offers substantial protection against COVID-19, including against hospitalization and death. Across all countries, Study 3001 generated high-quality, robust data at a time when the incidence of SARS-CoV-2 was increasing and new highly transmissible variants were emerging. Janssen's vaccine demonstrated 85% vaccine efficacy against severe disease with an early onset of protection as early as 7 days after vaccination. Importantly, for the primary analysis, there were no COVID-19 related hospitalizations in the vaccine group versus 16 in the placebo group. And there were no COVID-19 related deaths in the vaccine group compared to 5 in the placebo group. For protection against moderate to severe disease, there was 66% vaccine efficacy across all countries. And the onset of efficacy here was evident as early as 14 days and increased through day 56, especially against severe disease. In the United States, where study participants reflected the diversity of the overall U.S. population, vaccine efficacy was against moderate to severe COVID-19 was 72%. Protection against all symptomatic disease was consistent with the primary endpoint. And the high levels of protection were consistent across subgroups, countries, and regions, in particular areas with high incidence of circulating variants. So now let's turn to safety. A single dose of AD26 was demonstrated to have an acceptable safety and reactogenicity profile. The results were consistent with the tolerability and safety of our other adenovirus-based vaccines. So let's go back to the study population. SAEs, medically attended AEs, and AEs leading to discontinuation and deaths were collected on the 43,783 participants who make up the full analysis set. In addition, we enrolled a safety subset which collected solicited and unsolicited adverse events in 6,736 participants. We conducted our primary analysis after meeting the FDA guidelines for reaching a median follow-up of at least 2 months. The median follow-up after vaccination was 58 days, and more than half the participants in the full analysis had at least 2 months of follow-up. In the safety subset, nearly all the participants completed the 28-day post-vaccination period. I'll now turn to the solicited adverse events collected in the 7-day post-vaccination period. So on the next slide, you'll see a depiction of the solicited local adverse events, stratified here by grade and age. These events were transient, and more than 99% were of grade 1 or grade 2 in severity, and all resolved within 2 to 3 days after injection. And the most frequently reported local adverse event that you can see here is injection site pain. The frequency of grade 3 adverse events was very low overall, with a higher incidence in the AD26 group compared to placebo. For participants in the AD26 group, the most frequently reported grade 3 event was injection site pain at 0.4%. There were no grade 4s reported, and in the AD26 group, the frequency of solicited local AEs was similar between those who were seropositive for SARS-CoV-2 at baseline versus those who were seronegative at baseline. So here are the solicited systemic AEs, which you can see are higher in the AD26 group versus placebo. Most were transient and had a median duration of 1 to 2 days after vaccination. The most frequently reported systemic symptoms in the AD26 group were fatigue, headache, and myalgia. 98% of the solicited AEs were grade 1 or 2 in severity. Grade 3 events were infrequent and reported in about 2% of participants in the AD26 group. There were also no grade 4 events reported for this category. Fever was reported in 9% of participants in the AD26 group, with 0.3% being grade 3 among those 18 to 59 years of age, and 0.1% in those 60 years and older. All fevers were reported to have started on the day of vaccination or the day after, and had a median duration of 1 day. You can see that the reactogenicity profile overall is milder in the older age group compared to the younger age group. So let's turn to the unsolicited adverse events. On the next slide, you can see the rates for unsolicited AEs, serious and non-serious, in the safety subset, and this is 28 days after vaccination, and you can see that they're balanced between the two arms. Rates were also balanced in the full analysis set for medically attended AEs, any SAE, any SAE due to non-COVID related AEs or any death. SAEs, medically attended AEs and deaths were numerically higher in the placebo group. The imbalance between the AD26 and placebo group is mostly driven by the number of AEs associated with SARS-CoV-2 infection. None of the deaths in AD26 or the placebo group were considered causally related to the vaccine. Janssen analyzed the occurrence of various adverse events of interest identified by regulatory agencies and medical and scientific organizations such as the Brighton collaboration. And these events include those where there's a numeric imbalance with the numbers higher in the AD26 group, such as events of hypersensitivity reactions, as well as thromboembolic events. For the other events of convulsions, tinnitus, peripheral neuropathy, Guillain-Barré syndrome, and Bell's palsy, no causal relationship with the Janssen COVID-19 vaccine could be determined. The assessment of causality was confounded by the presence of underlying medical conditions frequently present in individuals with these adverse events of interest. All of these events are going to be included in further monitoring as part of our comprehensive pharmacovigilance plan. Hypersensitivity events were reported in 0.4% or 77 vaccinated individuals and 0.3% or 65 individuals who received placebo. Some participants reported more than one sign or symptom. As you can see in the table, serious non-serious dermatologic manifestations, particularly rash and urticaria, were the most common hypersensitivity adverse events reported. Rash and urticaria, both localized and more rarely generalized, were considered likely related to vaccination. In events reported as related by the investigator, the mean time to onset after vaccination was about 6 days, and the mean resolution was approximately 13 days. The vast majority of these events were grade 1 or 2. There were 2 serious adverse events in the AD26 group and 1 in the placebo group. One case of hypersensitivity was reported as an SAE in a vaccine recipient, with urticaria beginning 2 days following vaccination and angioedema of the lips, but no respiratory distress, and this began 4 days after vaccination. The event was likely related to the vaccine. We had another SAE of angioedema that occurred 23 days after vaccination on someone who was on enalapril, and this was considered unrelated by the investigator. Both participants recovered without sequelae. The results are similar to what we've observed with other AD26 vaccines. As of February 22nd, we had no cases of anaphylaxis meeting the Brighton collaboration criteria in the clinical program. However, earlier this week, we received preliminary reports of 2 cases of severe allergic reactions, one of which was anaphylaxis from an ongoing open-label collaborative study that we have ongoing in South Africa, in which approximately 70,000 healthcare workers have been enrolled. So we'll continue to closely monitor for these events, and this is outlined in our pharmacovigilance plan. On the next slide, you can see the overall incidence of thrombotic and thromboembolic events, both arterial and venous, were similar across AD26 and placebo group. A numerical imbalance was observed for the venous thromboembolic events. Most of these participants had relevant underlying medical conditions and predisposing factors that may have contributed to the use of these events, such as COVID-19 infection, prior history of DVT, new estrogen use, family history of DVT, prolonged air travel, or stopping anticoagulants. There's insufficient evidence to determine a causal relationship between these events and the Janssen COVID-19 vaccine. These events are included for further monitoring in the pharmacovigilance plan. The safety data from the 43,783 participants in our phase 3 study demonstrate that a single dose of AD26 has an acceptable safety and reactogenicity profile. Overall, reactogenicity to AD26 was demonstrated to be mild and transient in nature, and grade 3 events were rare. Most AEs were mild or moderate and generally resolved within 1 to 2 days post-vaccination. Adverse events of interest were thoroughly evaluated, and we will continue to monitor for these events in our comprehensive pharmacovigilance program. The safety profile is further supported by data from more than 193,000 individuals who have received at least 1 dose of Janssen's AD26-based vaccines in our other clinical studies and programs. In summary, the known and potential benefits of AD26 outweigh the known and potential risks. AD26 COV2S offers substantial protection, especially against severe COVID-19, including hospitalizations and deaths, irrespective of variants. And efficacy is consistent across age, comorbidities, race, and ethnic subgroups. For safety, we've shown that a single dose of AD26 has an acceptable safety and reactogenicity profile. The results were very much consistent with the tolerability and safety of our adenovirus-based vaccines in the platform. We do have plans in place for continued safety monitoring following emergency use authorization. And now that we've received the authorization, we will now amend the COV 3001 study protocol to facilitate crossover of participants who have received placebo to receive 1 dose of the vaccine. And this will be done as fast as operationally possible. Importantly, the vaccine is compatible within the existing distribution channels. It can be stored for 3 months at normal refrigerator temperatures and has a 2-year shelf life in regular freezers. But last and certainly not least, the Janssen vaccine was specifically studied with a one-dose regimen, which will greatly increase vaccination capacity and the ability to cover the population quickly. Let me conclude by thanking the participants who volunteered for this study, as well as our U.S. government partners and our collaborators. Thank you, and I'm happy to take questions.
Thank you very much for that informative presentation, Dr. Dworgy. So we're going to begin questions, comments. We're going to start primarily with the voting members, and then go on to liaisons. So please raise your hand if you have any questions. Let me begin with the following. So I'm curious about the Native, American Indian, Native Alaskan population. So under your slide for 39, they're not listed there, although they included 10% of the total population. Can you tell us what the VE was for that group? And I realize that it's a particularly small group among U.S. Native Alaskan American Indians. So what was the VE for that? And can you tell me, was protection against hospitalization and death similar in that group as to the other groups? And I'm sorry to bombard you with so many questions, but there were no data presented on this group. So please, could you give us as much information as possible?
Yes, so the first thing to clarify is that within the U.S. population, only 1% of the 10% is coming out of the U.S. So it's 10% overall. Now, I would like to, I don't see the slide here, so I'm just going to ask my colleague, Dr. Anne van der Bos from Statistics, to comment on the specific frequency. I know overall the numbers were low for that particular subgroup.
Thank you. Yeah, thank you, Makaya, Dr. Dworgy. So I will be indeed, the numbers were small in that particular subgroup. So as of 14 days, we observed 21 versus 41 cases, corresponding to a vaccine efficacy of 49%. And as of 28 days, we observed a vaccine efficacy of 32%, corresponding to 18 cases in the vaccine group and 26 cases in the placebo group. And as pointed out, the number of cases were relatively small with relatively wide confidence intervals.
And any comment on deaths or hospitalizations in that group?
So further following up on that, no, as the numbers were small, we did not calculate a severe disease in that population, or death, hospitalizations or deaths were not observed in that subgroup.
And my final question for you, so could the lower VE attributed to this group be related to the circulating variants in the countries where these groups were recruited from?
I don't think we have sufficient information to answer that question at this time. We do know that also the populations coming from Latin America were spread across a number of different countries. So it's difficult to say, but we're going to continue to look at this as we accumulate more cases to see if in the future we'll have more robust data to be able to address that question.
Thank you very much for indulging my questions. Let's go forward then with Ms. Bata.
Thank you, Dr. Romero, and thank you for this very excellent review of your study. I had just one question. Do you have any information about participants who may have had a prior infection?
So we have looked at that. We have approximately 9% of our population were seropositive at baseline, and about 0.5% were PCR positive. We only had one moderate case of COVID-19 in a U.S. participant that was positive at baseline. So there's really not enough information to be able to comment or draw any conclusions.
Okay, and any information about their systemic or local reactions?
Well, in general, we looked, well, not for that particular participant, but we did look at reactogenicity based on serostatus, and the both local and systemic reactogenicity are very comparable.
Thank you.
Thank you very much. Dr. Lee.
Thank you so much for that information-packed and efficient presentation. My question relates to the differential timing of the separation of the curves for moderate to severe disease versus severe disease. So I'm looking at slide 29, I think, compared to a slide a few later. Yeah, compared to slide 33. So this one separates at day 14, and on slide 33, the separation begins at day 7. So, like, to me, that implies that perhaps a moderate or a good enough immune response is sufficient against severe or critical disease, but perhaps a more robust immune response is needed against any symptomatic disease or moderate to severe / critical disease. So I'm wondering if you could just comment on the differences in those two pictures, and then also whether or not you can relate that to correlates of immunity that you found in your participants.
Sure, thank you for the question. Now, we have not identified a correlate yet. We will begin to conduct that work, which will certainly help to clarify some of these important questions. But we do know that traditionally it's often easier to prevent against severe disease than more mild disease, and certainly in terms of prevention of infection. So it's not surprising, at least to us, that the separation for severe disease is happening a bit earlier. You also see that that's reflected in the higher vaccine efficacy that we observe compared to the moderate and severe when you combine them. So it may be indeed that more is needed to prevent those milder infections. And as you saw, our case definition was quite broad and really seems to encompass the whole spectrum, so including milder cases. So that may be in part why we're seeing the difference.
Thank you. And then I have one more quick question or comment and question. I just want to follow up on Ms. Bata's comment about history of COVID-19 infection and understanding or having the information specifically on reactogenicity. I think that would be helpful in the future to break that out so that we can, counsel patients accordingly if there are any meaningful differences. And second, just wanted to ask specifically whether you saw lymphadenopathy as a systemic adverse event at all in your review.
Yep, and just to reiterate, and I know we don't have the slide up, but there really was no difference in reactogenicity. And we've had discussions with the working group about when we do the crossover to really look at that, because there might be more people who've had COVID that would get vaccinated later on, and we'll try to continue to capture that in hopefully larger numbers. But for now, we really don't see a difference. In terms of lymphadenopathy, that has not been, and we've been evaluating 26 vaccine candidates for quite some time. Lymphadenopathy has not been a prominent feature. So after several years and multiple studies, we looked at our solicited adverse event profile that we traditionally thought were associated with Ad26. We didn't include lymphadenopathy because it was just not something that was seen. We had a broader set of terms, but narrowed them down to based on what looked really specific to the viral vector, and it didn't include that.
Thank you, Dr. Paling.
Yes, thank you for this great presentation. I wanted to ask about pregnancy and the use of this vaccine. What is the experience with this vaccine, and then what is the broad experience with this adenovirus vector? Thank you.
Very much for the question. So we had relatively few pregnant women or people who became pregnant after receiving the vaccine. So 8 in total in this case. So it's quite difficult to draw any conclusions, but there were no safety issues that we identified post-vaccination in terms of the reactogenicity. And there have been some spontaneous abortions. I can't quite remember the number, and even more so in terms of elective. So we don't really, when we have 2 that are continue to be pregnant, so we'll monitor those outcomes. But in terms of the platform, we have a bit more data coming out of our Ebola vaccine program. In addition to just monitoring that we do for all of our studies, we capture pregnancies. So we vaccinated approximately 1,600 people who then became pregnant or were actually pregnant at the time of enrollment. We have 2 studies where we're enrolling women of all trimesters, both in the Democratic Republic of Congo and in Rwanda on the border of DRC, where there was increased risk of Ebola, and those activities started last year. About 1,500 of the women from the number that I mentioned were coming out of those 2 activities. So we're monitoring for the outcomes. There are about 900. We haven't seen any safety signals to date. The birth outcomes and other important outcomes seem to be in line with the background rates at the moment. And from a reactogenicity point of view, there hasn't been anything that stood out based on the numbers we've enrolled to date.
Okay. The second question I have is when I was reviewing all the data, it looked like there's a few people with cancer, HIV, and immunocompromising persons were enrolled, maybe about 1,500. Do you have any data on the impact in that group?
Impact in terms of safety?
Safety as well as vaccine effectiveness.
Well, yeah, so we haven't done a breakdown or analysis of subgroup for safety yet, although that is something that we have planned. We have very few cases in the HIV positive group to date, so that's also something where we can draw conclusions at this moment. And I think for the immunocompromised, it's a general category, and apologies, we don't have the list or of all of the different types that were enrolled in this study, but I think overall we saw 2 cases. So it's something we'll continue to observe. We were encouraged by the fact that we did have quite a range of subjects that participated in the trial, but we still have yet to analyze the data.
Thank you.
Thank you very much. Dr. Bernstein, please.
Thank you, Dr. Romero. And thank you for presenting so much detail so succinctly. I had 2 questions. One is, what was the thinking behind choosing to initially study 1 dose rather than a 2-dose series like other vaccines?
Thank you for the question. So, well, and this is also perhaps influenced by some of our experience with the Ebola outbreaks many years ago. For an outbreak setting, I mean, a single dose obviously has tremendous advantage in terms of being able to rapidly roll out mass vaccination and not having the complexity of having to have follow-up, and also to be able to administer or optimize the numbers of doses administered. So that was in part one of the main reasons why we wanted to evaluate the single dose, but it was also influenced by our extremely strong preclinical data showing full protection after a single dose. And I think once we saw that, it became clear that that was a viable option. In terms of the 2-dose schedule, that was something we always intended to implement as well, just because based on our experience, we know that 2 doses can be more immunogenic and could lead to more durable efficacy. But with a 2-month interval, that also means that you have results later. And so I think both strategies can be utilized, but we still believe that the single dose is optimal for a pandemic setting. Should SARS-CoV-2 become something that it becomes part of the routine immunization schedule in the future, should the data support this, of course, it could be that a primary series for certain age groups or populations could be a 2-dose series instead of 1. But that will be driven by the data that we generate. We also are looking at boosting intervals out of our phase 1 2A study so that we can get an idea of once hopefully we identify a correlate. When would be
okay. Hi.
Hello? Can you hear me still?
Please mute your phones, everyone, if you're not speaking.
Thank you. The other question that I had, actually in your early phase studies in COV, 1001, 1002, and 2001. Why were healthy adults greater than or equal to 18 to 55, and then healthy adults 65 and older chosen? Why the gap?
Yeah, so thank you for the question. We were trying to, typically the age range is either 18 to 45 or 18 to 50, and we were hoping to really expand to the broadest age group possible. There were some concerns about starting to evaluate the elderly initially, and so we had to generate some preliminary data in that earlier age group compared to before we could go into that older age group. But in early discussions with the FDA, we asked if we could expand at least that age range in case there were challenges or issues with the older age group, that we'd at least have that expanded population. So the gap, of course, we closed in phase 3. We included all the age range, but that was originally how we ended up with that gap.
Thank you. And my last question, I noticed that the multi-dose vials have 3.1 ml in them. Do you anticipate that will get 6 doses or 5 doses per vial?
The current plan is to have 5 doses per vial, with the extractable volume will enable the 5-dose extraction. It would be, of course, of interest to get more out of it if we can, but at the moment it's 5.
Thank you.
Thank you very much. Doctors Freihofer and Dushin, I see your hands are up, but I'm going to skip you. As I said, we're going to talk with the with the voting members first, and we'll come back to you, I promise. Dr. Sanchez.
Thank you for the presentation, very clear and certainly encouraging. Few questions. First of all, in terms of the case definition, moderate to severe, the case definition that was the primary outcome. The symptomatology, one of them was any one of the following new or worsening signs or symptoms, and one of them was abnormal saturation of oxygen, but still greater than 93% on room air. That sounds a little bit confusing to me.
Yeah, so it's basically 94%. So it included, because the FDA definition for severe critical, as you can see, is an oxygen saturation at or below 93%. So we wanted to make sure that those were not overlapping definitions.
But if they had a positive PCR and the O2 sat was 95, was that considered severe or moderate or severe case?
It was not considered, well, it wouldn't meet the case definition for moderate if it was 95% no, but of course they might have had symptoms or other criteria that would make them a moderate.
Yeah, I'm just misinterpreting the case definition wrong. The case definition for moderate was the following: of SARS-CoV-2 positive and any one of the following new or worsening signs or symptoms, and under that is abnormal saturation, but still greater than 93% on room.
Yeah, so that basically is anyone who had a SAT of 94%. And so if they didn't, but they met any of the other criteria on that, the single criteria, they would be a case. So if it was 95% oxygen saturation, it would have been considered normal, or it would have gone into the mild category, depending on how many symptoms you have.
This is Jerry Sadoff. Maybe I could clarify. We took the moderate definition word for word from the FDA guidance to industry, which has that peculiar wording, greater than 90, greater than 93, not greater, just as you're trying to interpret it. So that's a word for word, and then that translates into 94 is the only one that would count for the moderate, because the abnormal is less than 95. But the wording came from the FDA's guidance to industry, so apologies for that.
Well, that's okay. I just wanted, because the way it reads, if you have one that's 96, it would still fit into that category.
Yeah, it was unclear to us also, but that's how we interpret it.
Okay, thank you. And then I know that your primary efficacy was moderate or severe by your clinical criteria, and maybe I missed this. Have you looked at what the efficacy was when you include the mild cases or not?
Well, yes, and as you probably saw or you caught, that there were only 4 cases in total that were categorized as mild. So effectively, there's no difference in the vaccine efficacy.
I missed that. The other question I have, I think I'm really pleased that you'll be doing adolescents and children and going down all the way to neonates and certainly in pregnant women. I just had a question. Have you done any animal studies, or I know you've done some animal studies looking at the vaccine, but at least I guess my question is the safety in pregnant animals and subsequently in women. And this may be a little bit naive, but when the cells produce the spike protein, does this spike protein, does it cross the placenta? Can it be found in the placenta? And does it cross into the fetal compartment?
So we have done a reproductive toxicity study, and we've seen no adverse effects that would preclude evaluation in humans. We do see that. Now you're asking about the vaccine or IgG, because there is placental transfer of antibody from the mom to the fetus.
No, I would expect that, yes. But I'm asking more about how long. I'm asking more about the spike protein. Is the spike protein, and I really don't know if it happens with other vaccines, for instance, either. In terms of the pregnancy cases, but I just don't know the size of this spike protein and whether it crosses the placenta, could be found in the fetal compartment.
I don't think we've tested for that. Maybe I can just ask Professor Hausemacher to see if we've done anything in our non-clinical study.
No, this is Hanneke Schuitenmaker speaking. We have not studied that in detail. I think an important thing to mention is that our spike protein in vaccine context is membrane bound, and with that we have also tried to reduce circulation of soluble protein, but we have not studied transplacental migration of even fragments of the protein at this point.
Thank you. I was just wondering because I don't know how long the spike protein lasts in the circulation. Or how long it can be detected to see if there's any possibility of it crossing the fetal compartment and either causing some local placental or fetal response at all.
So this is Jose again. I don't want to cut off conversation here, but I would like us to focus on the subjects at hand. I mean, those will be questions that are very interesting, both to me as a pediatrician. But we're dealing with the vaccine that's before us today, and the populations that we're dealing with. We can talk about these later. So please focus your questions.
Well, my other question is, how about co-administration with other vaccines? Was that excluded in your study, or any?
Yeah, well, we required a spacing. So for inactivated vaccines, a minimum of 2. For live replicating vaccines, it was minimum of a month. We do plan on doing co-administration studies with, for example, the influenza vaccine. That will be an important one, and potentially others, but we haven't yet started those studies.
Excuse me. And then finally, there's a lot of vaccine hesitancy among different groups, and one of them, is your vaccine produced with fetal cells from aborted fetuses by any chance?
Our vaccine does not contain any fetal tissue.
Thank you.
Thank you very much. Ms. McNally, please.
Thank you. I'm trying to understand if a 2-dose primary series is ultimately determined to be safe and effective, what the impact will be on those who've received the 1-dose primary series, if that is ultimately recommended. Thank you.
Thank you for the question. Well, I think, yes, we have to determine whether or not, first of all, there is a difference in efficacy with the two-dose schedule. And we are evaluating boosting intervals following a single dose, 6 months out, 1 year out, and 2 years out. So we should have some information that would help guide that decision-making when the time comes.
Thank you. Dr. Cotton.
Thanks for taking my question. On slide 39, it looks like there's a pretty significant discrepancy between men and women with respect to vaccine efficacy against moderate to severe or critical COVID-19. So I was wondering if you could comment, it's almost 70% in men versus 60% in women. Obviously, the stats show some overlap, but that's still a pretty dramatic difference. And women are generally smaller, so in theory, the vaccine dose might have been a little higher per body weight. Does the company have any thoughts about that?
Thanks for the question. Yeah, I guess there are differences, but because of the overlapping confidence intervals, we didn't view that as something that was substantial. Of course, we could evaluate that in much larger numbers once the vaccine is rolled out. Dr. Van der Bos, do you want to comment further on that?
Thank you, Dr. Diorgi. From a statistical perspective, I agree with that. The confidence intervals are largely overlapping. And when we look at the point estimates, it's all within the range of variability that you can expect with vaccine efficacy estimates of 66% overall. So the difference that is observed here can be attributed just by variation and not necessarily being a true difference here. It cannot be distinguished because of that. So it's in line with the overall vaccine efficacy and natural variability to conclude.
Thank you.
Thank you. Dr. Long.
Yes, I have a question. I'm trying to understand the intensity and density of exposure of the groups. And I might be able to calculate this, but I can't figure out where the denominators are. If you limit yourself to the United States, it seemed as if there were a goodly number of subjects and pretty small numbers of cases and smaller numbers of hospitalizations. Do you have any kind of a sense, if you can put that in percent of subjects in the placebo group who were infected moderately or mildly symptomatic or severely symptomatic? You get down to really small numbers so quickly. I'm just kind of trying to understand the intensity of exposure. I suspect you were also asking people to mask and to socially distance. So could you just give us a sense of that? Thank you.
I'm sorry, I missed the last part of your question. Could you're commenting on the small numbers in the U.S. population in terms of cases. Are you asking what the distribution of the severity is among those cases?
I'm wondering, right. It seems like few cases in the placebo groups that you showed, and I couldn't figure out who was U.S. and who wasn't. But then also many, many, many fewer than you might expect of symptomatics who were actually hospitalized. So I wonder if you just have some sense of that.
Perhaps I'll ask Dr. Van der Bos if she has any particular information that we maybe could pull up to share.
Thank you, Dr. Drogi. I don't think we have a slide related to that, but I was wondering if I understand the question correctly, that we want to see the distribution of moderate to severe cases in the U.S. Is that your question? Can you confirm that
I'm sorry, I'm not making myself very clear. You had some, I'm thinking about the placebo group only at the moment.
Yes.
And it seemed like you had very few cases of coronavirus disease in the placebo group. And so I am just wondering a little bit about the intensity of the exposure, the density of the exposure, of the number of organisms, and wondered if it was relatively small for the whole populations if you weren't exposing these people in the time of a lot of cases in the pandemic, et cetera, to try to generalize your results?
So what we have seen in the trial, when we look at the placebo group, the overall incidence was actually quite large. So we had an incidence of 20% when we looked at symptomatic COVID-19 disease, indeed. And then a fraction of that was severe disease, depending on the age group where the subjects were in. The younger population, 18 to 40-year-olds, had a lower incidence of severe disease and was more towards mild. And then the group above 60 years had a higher incidence, relatively speaking, with severe disease. And when we look at the trial over in each of the different countries, and specifically in the US, we see that the trial was conducted at the height of the pandemic in the US. So with peak trial incidences of 20% among that size, also in the US. So quite large. Yeah.
Thank you so much. I didn't figure that out correctly. Thank you.
Thank you. So I'm not seeing any more hands from the voting members. Let me go ahead and turn to our liaisons. Dr. Freihofer, thank you for waiting so patiently. Go forward.
Yes, Sandra Freihofer, American Medical Association, and thank you so much for that presentation. I'm a general internist, and the vast majority of my patients have multiple comorbidities, and most of my patients are older. I greatly appreciate the fact that your study included about 40% of patients, had comorbidities, and that your target for those over 60 was about 30%. And I am reassured by Dr. Fink's comments and the reaction from the VRBAC panel of experts about the smaller number of older patients with comorbidities leading to imprecision in the vaccine efficacy results. But they are lower. And will there be any attempt to get this information out more quickly about this subset of older, sicker patients, so we can confirm that indeed, this vaccine does work, or would we have to wait for like a BLA for that? My other question is, after this vaccine, I appreciate on slide, I think 11 or 12, you talked about what happens once the vaccine's injected into the body. But how long do vaccine fragments hang around? Where do they go? How does the body break them down? And is there any concern that them sort of hanging around could cause other issues or other problems? Thank you.
Thanks for those questions. Well, just to reflect further on the comorbidity question in older adults, we actually think this is artifact. And again, because of the small number of cases, and this is a subgroup of a subgroup analysis, and I think we're only able to even have some results because we have so many cases. But if you look at the vaccine efficacy in that subgroup after day 14, the vaccine efficacy is completely consistent and in line with the overall data set. So with narrow confidence intervals, and when you get to the endpoint that's 28 days after vaccination in that subgroup, that's where you start to see much wider confidence intervals because the numbers are just simply lower. And in terms of biologic plausibility, it just doesn't make sense that the immune responses don't drop that quickly in our vaccinees. And in fact, it plateaus, and we see that efficacy does increase with time after day 29. So it just doesn't fit. There's no reason to believe that it doesn't work. Yes, of course, we'll have more cases, but we also looked at hospitalization in this subgroup, and it's 82% vaccine efficacy. So we're still protecting in comparable ways to the overall data set. And again, I just think this is a question of small numbers after day 28, and not in line with the rest of the data set that fully supports protection and is comparable in that group.
Thank you.
And where does the vaccine hang out after it's injected, and how long does it hang out? How long are those fragments there?
So I'll answer, and then since we have Dr. Custis on the phone, if he wants to add anything, he can. So we've done a number of different biodistribution studies in animals over the years, and we see that from the point of injection, once the adeno is in the muscle cell, it drains to the regional lymph node and can persist. It's on average about 3 months, but we have detected the vector out to 6 months in a small number of animals, and then it's subsequently cleared. We haven't seen any issues related to that. Dr. Custis, do you want to add anything?
No, I think you summarized it very well.
Thank you.
That's your question.
Did you have more questions?
Thank you. Thank you so much.
Okay, thank you very much. Dr. Daly, forgive me, I skipped you. I didn't see you. I lost you in the shuffle there. Dr. Daly from voting members.
Oh, yeah, no worries at all. So, I had a comment and a question. We're all concerned about the variants and about the efficacy of currently approved vaccines against the variants. And what strikes me is that you made the most of the opportunity presented by the countries selected and by having sequencing data to really look at the efficacy against variants. I think we all need to be cautious here, but I was cautiously optimistic. It looks like the vaccine has high efficacy against hospitalization and severe disease, including against variants. So my question is, will the two-dose study that's ongoing be conducted in sites with a high prevalence of variants so that we'll have evidence about efficacy of the two-dose schedule against variants? Thank you.
Yes, thanks for the question. And yes, it's an important one. We do have some overlap in terms of countries. So we are enrolling that study in South Africa, also in the UK. And as you know, B117 has been circulating there. And so we do expect to have some data once we start to accumulate endpoints.
Thank you.
So we're going to stop. We're going to continue to take questions, but we're going to go. We've got 1, 2, 3 more questions. We will end with Dr. Dushin. So Dr. Kimberlin, please.
David Kimberlin, AAP Red Book. On slide 9, you simply lay out, the additional studies that are planned, and I'm interested, obviously, in the pediatric studies. You say that studies are planned 0 through 17 years of age, and that the adolescent study will open for enrollment soon. Can you give a little bit more information on that adolescent study, ages, actually when it will start, and what are your plans for de-escalating to younger ages, the pre-adolescent, the child, down to the infant?
Yes, thanks for the question. And so we have 2 studies that will include the pediatric populations that are going to start very, very soon, and subsequently we may look at immunocompromised children in the future. But we're starting with, we amended actually one of the studies that I mentioned earlier, the 2001 study, which sort of had a different purpose, but because it was open in multiple countries and there was an interest expressed in adolescents, we amended that protocol. Now that should start and open to screening next week if all goes as planned. And that age group will be 12 to 17. But our aim is really to get data as quickly as possible on the 16 to 17-year-olds, such that potentially we could submit those data for review, and maybe they could be incorporated as part of an EUA. And then we'll then go to the 12 to 15-year-olds. And so that's one study, and we estimate approximately 660 participants will be recruited in that study. And then we have another study that comprises the whole age range of pediatrics, and so we will do an age de-escalation, as you mentioned, starting again with the adolescents and then moving down into younger age groups, and we'll potentially look at different dose levels depending obviously on the results coming out of that study. But the total data package we intend to have for the pediatric population will be roughly 3,000.
And do you have a time frame for that age de-escalation study for when it might start?
Yep, we hope by the end of March, early April. We've been doing feasibility, and we're almost ready to go. So as soon as we can.
I greatly appreciate that. Thank you.
Thank you. Dr. Shah.
Thanks, Dr. Romero. This is Nirav Shah from the State of Maine Center for Disease Control on behalf of ASTO. I had a question regarding the anaphylaxis data and the attendant observation period that often is intended to witness such events and prevent them or respond to them. I noted that the FDA in its EUA recommended that providers follow the US CDC's guidelines on post-vaccination observation. I also noted, however, that in the clinical trials, there were no anaphylaxis events, so I appreciate you noting the 2 emerging cases that you've just been made aware of. Among the benefits of this vaccine from an operational perspective, among the numerous benefits, would be the potential to forego the observation period because the more well-known adenovirus vector does not necessarily generate that type of anaphylaxis. My question is, do you have a sense of, in the subsequent studies, other than the 2 notes that you mentioned in South Africa, have there been other hints of anaphylaxis noted? And then B, with respect to the 2 cases in South Africa, are there any other details that you can provide that might help state officials as we are navigating the advisability of the observation period? Thank you.
Yep, thanks for the question. Actually, so for our early development studies, we had for a while monitored for a 60-minute period, and really we don't see immediate reactions. In this program, I think the other studies, apart from 3001, and the first sort of the safety run-in phase, we monitored people for 30 minutes, and based on no immediate reactions in terms of observation, we reduced that to 15 minutes. So the information that we have, that I've presented today, reflects that we have not seen anything happening in that immediate time frame. And I'm sorry, your next question?
Are there any emerging pieces of the investigation you can share from South Africa? Again, the potential of this vaccine opens up things like true drive-through vaccination at the state and local level. And if the observation period is needed, then that takes us in one direction. If the sense is that it may not be needed, notwithstanding the FDA's pronouncements in its EUA, that takes us down an even more widespread application. Thank you.
Yep. Thank you for the question. And of course, those are important considerations. So the one case that was reported as a SUSAR, the one that met the Brighton collaboration criteria occurred in a 39-year-old woman who developed a fever, swollen tongue, and difficulty breathing a few hours after vaccination. She had hives on her limbs and upper trunk. And so she was admitted to the hospital, treated with hydrocortisone and Phenergan, and the last that I understood is she's stable. I don't know if she's been discharged, but there have been no reports of further outcomes. And the other one did not meet the Brighton collaboration criteria. This was a participant, I believe 41 years of age. She developed fever, chills, and other systemic symptoms accompanied with a drop in blood pressure approximately 10 minutes after vaccination. And that's the only information actually I have at this moment. But I don't know that she was admitted to the hospital, but it was deemed medically important. Not quite the same category as the first case.
Thank you very much.
Dr. Dushin.
Thank you. Just in follow-up to Dr. Shah's question, I'm wondering if our CDC subject matter experts at some point could weigh in on the recommended observation period, both in general and for this vaccine. And then my question is on slide 34, vaccine efficacy against severe critical COVID-19 over time. Thank you. I'm wondering why this analysis was only done with the centrally confirmed COVID cases, and whether or not you have a similar analysis for hospitalization, or there were not enough hospitalizations to do that. Thank you.
Yes, thanks for the question. We have a number of different of these plots. I think in the interest of time, we didn't show all. With respect to hospitalization, though, I'm not sure we have those data, but Dr. Van der Bos, perhaps you can comment on what we've explored.
Indeed, for the hospital, thank you, Dr. Duogi. For the hospitalizations, there were too few cases to draw a curve like this. As you can see here, the imprecision gets lost, so we didn't do it for the hospitalization. Over.
Okay, thank you. And can you comment on why this only includes the centrally confirmed COVID cases?
Yes, indeed. So thank you for that question. So for the severe disease endpoints, we have, and the moderate to severe for the key secondary and primary endpoints, we actually use the centrally confirmed cases to present the data. However, we also have explored the same curve and the same analysis using the non-centrally confirmed cases, and the graph or the picture, the message that you can see from this visual is similar in that data set, but it's not shown here in the slide nor available in the backup slides.
Thank you.
Thank you. Our final question will come from Dr. Freihofer. Dr. Freihofer.
Thank you, Sandra Freihofer, American Medical Association. This is a follow-up question about the anaphylaxis. I noted in the summary provided by FDA that one of the vaccine ingredients is polysorbate, and for the mRNA vaccines, the CDC has listed handling patients that have an allergy to polysorbate a little bit differently. Have you in any way thought about polysorbate as possibly being a reason for some of these skin issues and other allergic reactions you've seen with your vaccine?
Well, it's difficult to say because, well, one, we haven't really seen this pattern per se, but polysorbate 80 is used, very commonly used in vaccines. Some of the other examples would include Gardasil, Prevnar, a couple of the influenza vaccines. So the levels that we include in our vaccine are lower or comparable. So it's not clear that would be the culprit, but it's certainly something obviously we would monitor for. And just looking at our platform, I mean, again, we haven't seen any safety signal related to this previously. So we'll continue to monitor, but certainly that's something that, again, I mean, it's in a lot of different ingredients, even in foods that we eat. So right now we're not associating a link with that specifically at the moment.
Do you know if any of those cases had an allergic reaction, were allergic to polyethylene glycol? Because the CDC materials on their website indicate there could be a cross reaction with the polyethylene glycol and the polysorbate.
Yeah, I don't know if we've asked that information. I also don't know if participants even would know if they had that allergy. But it is obviously an important question and something that hopefully we can monitor.
Thank you.
Okay, we'll end the session now. Dr. Droji and your team, thank you very much for the presentation and for taking our questions and answering them. So at this point, we'll take a 15-minute break, and we will reconvene at 17 minutes past the hour. Thank you very much.